Good evening, everyone, and welcome to our live webinar on cardiovascular pathology. Today's session is part 4 of our ongoing series on cardiac anatomy and dissection. This lecture will focus on the left side of the heart. Our speaker is Dr. Pradeep Vaideeswar. He doesn't really need an introduction, but for those who do not know him, Sir is additional professor of pathology at St. GS Medical College and KEM Hospital, Mumbai. The talk will be followed by a live discussion by our expert panelists. We will also be accepting questions from the audience through our Facebook page, Cardiovascular Pathology. Sir, I would like to invite you to begin.
Can you all see the screen?
Yes, sir.
Yeah. Okay. Hello, everyone. Welcome to the fourth and final session of examination of the heart. I again wish to tell you all that these series of lectures are for an approach to cardiovascular pathology at autopsy, and the same features can be applied even to explanted hearts as well. Now, to recapitulate certain points which were covered in the previous 3 sessions, the first session was devoted to gross examination of the anterior and posterior surfaces of the heart. In the second session, we saw something about coronary arterial dissection and myocardial assessment. And in the third session, we went on with the cardiac dissection, the cardiac weight, and then saw the examination of the right side of the heart. As I told you earlier, the heart is usually cut as per the flow of blood, that is the Furchow's inflow-outflow method, which has withstood the test of time, and both the right and the left-sided chambers are described with reference to their inflow and outflow tracts. Further on, the chambers have to be described as cavity size, appearance, and texture of the endocardium, and we also have to measure the thickness of the myocardium. Atrioventricular valves should be described with reference to the size of the annulus, the commissures, leaflets, and the subvalvular apparatus, which is composed of the chordae tendineae and the papillary muscles. The arterial valves should be inspected for the size of the annulus, commissures, cusps, and their number. And we also have to look for the presence of vegetations which appear on either the mural as well as the valvular endocardium. With this background, let us now go to the left side of the heart. Now, the left side of the heart is also dissected through 3 cuts. The first cut is made over the roof of the left atrium by joining the right and left superior pulmonary veins and extending a little into the appendage. After opening, the mitral valve is inspected for any pathology. The orifice usually admits 2 fingers, which is again a rough estimate. The second incision, as you can see here, is taken along the left border of the heart from the left atrium into the left ventricle through the mitral valvular orifice, cutting through the posterior mitral leaflet. Now, since there is a normal anatomical fibrous continuity between the mitral and aortic valves, the third cut is necessarily made through the mid portion of the anterior mitral leaflet and the wall of the left atrium to enter into the ascending aorta. And this is the usual practice if the mitral valve is normal. Now, this is the end-on view as seen from the left atrial aspect, and we can see that the mitral valve here is definitely abnormal with large amount of calcific debris and ulceration. Thus, whenever there is a mitral valvular pathology, a valve sparing cut is employed where an incision parallel to the anterior interventricular septum is taken to enter the ascending aorta. So, this is the modification that we make as far as the left side of the heart is concerned, especially when you're dealing with a significant pathology of the mitral valve. Now, this is the opened out left sided inflow tract and the outflow tract. The inflow tract comprises the left atrium, the mitral valve, and the left ventricle. And the outflow tract is the left ventricle, the aortic valve, and the ascending aorta. Now let us come to the morphology of the left atrium. In sharp contrast to the right atrial topography, the appearance of the left atrium is almost featureless. The pectinate muscles are confined to the left atrial appendage. The endocardium is naturally thick and opaque, and the septal aspect is marked by shallow, irregular pits. And as we saw in the first session, the left atrial appendage opens into the main left atrial cavity through a very small opening, which is quite different from the large opening we saw of the right atrial appendage into the right atrium proper. Now, let us see some of the common abnormalities that we can get in the left atrium. What I showed you earlier was the patent foramen ovale from the right side. Now, this is the appearance of the patent foramen ovale as we see from the left atrial aspect, and you can see that this is only probe patent. This is an example of what is called as a cribriform secundum atrial septal defect, where there are multiple sieve-like or colander-like lesions which are present in the interatrial septum. And incidentally, this patient had a paradoxical thromboembolism which had produced multiple small infarcts in the kidney and the spleen. And here on the lower aspect of this interatrial septum, we can still see small adherent thromboemboli. So this was an example of a paradoxical embolism in a setting of cribriform atrial septal defect. Here we can see a large, smooth-surfaced polypoidal mass lesion which is attached to the interatrial septum. This was an incidental finding at autopsy, and this is the classic morphology of a solid type of left atrial myxoma. Now, this is an example of a similar solid, glistening, firm polypoidal projection into the left atrial cavity. But here you can see that this polypoid mass lesion was coming through the right-sided pulmonary vein, and in addition, it has something like a beard which is present towards the lower aspect, and this, to our surprise, was a metastatic adenocarcinoma of the lung, which was projecting through the pulmonary vein into the left atrial cavity. So these are some of the common and rare polypoidal mass lesions in the left atrial cavity. Let us then come to the second component of the inflow tract, and that is the mitral valve. The mitral valve has two leaflets, the anterior and the posterior leaflet, and hence it has two commissures, the anterolateral commissure and the posteromedial commissure. The anterior leaflet has a greater width and appears a little tongue-shaped. The subvalvular apparatus is represented by the thin, delicate chordae tendinae, which are anchored to fairly constant anterior and posterior group of papillary muscles. So this is the normal morphology of the mitral valve and its subvalvular apparatus, all of which can be modified depending upon the type of mitral valvular disease. So here is an example of the inflow tract which shows dilatation of the left atrial cavity. There is also hypertrophy of the left atrial myocardium, both of which are produced by a severe degree of involvement of the mitral valve. Both the commissures are markedly fused. The anterior and the posterior mitral leaflets are extremely thickened and rigid in appearance, and apart from that, even the chordae are markedly thickened, shortened, and completely fused with the valve leaflet. So, this would be an example of a rheumatic mitral stenosis of a very severe degree. Now, because there is mitral stenosis, the stenotic jet has produced a lesion over the anterior papillary muscle, which shows a ladder like appearance. So, all this is nothing but endocardial thickening produced by a jet of the stenotic orifice. In contrast to the narrowing of the orifice, here we see that the mitral annulus is definitely dilated. There is no abnormality of the commissures, but the valve leaflets, both the anterior as well as the posterior, they appear more billowing, or they show a billowed appearance, which is a characteristic of a mitral valvular prolapse, which produces mitral regurgitation. And because of this, there is a prominence of the scallops of the posterior mitral leaflet. Along with that, you can also see that many of the chordae appear elongated and redundant. So all these are features of a chronic mitral valvular regurgitation produced by mitral valvular prolapse. And because there is regurgitation, there is dilatation of both the left atrium as well as the left ventricle. The next important aspect that we see are the vegetations. So here we see a very crumbly, tan colored, minute pinpoint vegetations which decorate the entire lines of closure. Along with that, there is fusion of the commissures, thickening of the valvular leaflets, as well as prominent changes in the chordae. So the diagnosis has to be rheumatic verrucous endocarditis. Similar vegetation seen at the line of closure, but these appear a little more friable. They are not associated with any significant change in the commissure, the leaflet, or the chordae. So, in this particular case, we are dealing with a non bacterial type of endocarditis, which in this instance is totally bland. So, this is an example of a non bacterial thrombotic endocarditis, very commonly seen with hypercoagulable states. So, all these are examples of a non infective type of endocarditis. But here, when you look at these vegetations, these are extremely bulky. They are yellowish white to brown in color. They occupy the entire surface of the leaflets, and they are also extending onto the chordae tendineae. So, this morphology is typical of infective endocarditis. Please note that the mitral valve in the background appears normal. So, this is infective endocarditis affecting normal native mitral valve. But here you have almost flattened reddish pink vegetations which are present over a deformed mitral valve. Why I say deformed? Because when you look at this particular aspect of the mitral valve, we can see the stigmata of chronic rheumatic heart disease in the form of leaflet thickening, mild caudal fusion, and significant caudal changes. So, this was an incidental rheumatic mitral stenosis with a lopsided involvement of the mitral valve. And this patient was a diabetic. She had left upper limb cellulitis, which explains the development of infective endocarditis. Now, this is another example of rheumatic verrucous endocarditis, but here the vegetations are almost healing. There is also verrucous endocarditis of the posterior wall of the left atrium, what we call as the McCallum's patch. And this verrucous endocarditis has produced a complication in the form of rupture of the chorda. So here the mitral regurgitation is explained not only on the basis of acute rheumatic fever, acute rheumatic myocarditis, but it is further accentuated by this caudal rupture produced by the verrucous endocarditis. Here we have a rheumatic mitral stenosis. We can see the presence of calcification and ulceration. And because there is left atrial dilatation, there is relative stasis of blood within the cavity, which predisposes the production of thrombus within the appendage. So here the mitral stenosis is complicated by the formation of thrombus, which can occur commonly in the left atrial appendage, but it can also occur as a mural thrombus in the left atrium itself. And that is why, whenever a surgery is done for the mitral valve in a setting of rheumatic mitral stenosis, they can either do an interventional or a surgical closure of the left atrial appendage. Now, here is an incidental finding at autopsy, and very uncommonly in this particular case, it has produced an abnormality of the mitral annulus. So, as I told you initially, that there is a true anterior annulus, a true posterior annulus. So here there is an involvement of the posterior mitral annulus, and here it shows the presence of dilatation which occurs below the posterior annulus. So this is an example of a submitral aneurysm. Another finding here is a congenital peculiar appearance of the chordae tendineae, where it produces a mesh-like configuration, and along with that there is also some caudal vegetations which appear as granular focally calcified vegetation. So this is an example of a congenital deformity of the chordae tendineae in this particular patient, and incidental calcified vegetations over the chordae, possibly of the non-bacterial thrombotic type. So please remember that you may get incidental findings which may or may not be clinically significant, but all this has to be documented carefully. With that, we come to the appearance of the left ventricle. Now, the left ventricle is finely trabeculated with a thicker, compact portion measuring about 1 centimeter. Now, the left ventricle is divided into the basal third, which extends from the mitral annulus to the tips of the papillary muscles, the middle third, which extends from the tips of the papillary muscles to the attachment of the papillary muscles, and the apical third, which extends beyond the base of the papillary muscle to the apex of the left ventricle. Now, this classification is very useful for delineating the extent of a myocardial infarct. It may also be of use when you're talking about the extent of involvement in certain non ischemic myocardial disorders. So you can see that this classification of the left ventricular chamber has no bearing to the classification which we used for the right ventricle, which is of extreme importance when you're talking about congenital anomalies. So, most of the congenital anomalies are classified looking more at the right side of the heart rather than the left side of the heart. Now, what are the changes that we can get in the left ventricle? Here we see multiple polypoidal, firm, friable, pale yellow lesions which are projecting from the intertrabecular spaces almost like electric bulbs. These are nothing but fresh mural thrombi which has occurred in a non-ischemic pathology because of septicemia in this particular patient. This shows a diffuse endocardial thickening, which is predominantly present in the inflow and part of the outflow of the left ventricle. You can see that this endocardial thickening extends a little into the subendocardial myocardium. So this was a case of an fibrotic phase of endomyocardial fibrosis, which is an example of a restrictive cardiomyopathy. And though it is showing an extensive involvement, this again was an incidental finding at autopsy. Now, sometimes you can also have abnormal cause, as we can see here, and this sometimes produces some kind of electrical abnormality leading to sudden death. And as I told you earlier, even such subtle anomalies have to be documented. With that, we come to the outflow tract of the heart. And here we can see that the outflow tract, left ventricle, aortic valve, and the ascending aorta. Please note, in contrast to the right ventricular outflow tract, the left ventricular outflow tract is relatively smooth with slight thickening of the endocardium in the subaortic region. Now, the cusps of the aortic valves are actually two anterior and one posterior. Please note that there is a discontinuous transverse ridge which is present here, and this is the sinotubular junction. The right and the left coronary arterial ostia are seen below it within the sinuses of Valsalva, and hence the cusps of the aortic valve are designated as the right, left, and the non coronary cusps. Now, this position of the ostia is very important. I repeat, they are present within the sinuses of Valsalva and below the sinotubular junction. If you look closely at the free margin, we can see some kind of a thickening which is called as the nodulus of Arenti. You can also clearly see that the line of closure is very well demarcated, and the portion which is above the sinotubular, above the line of closure and below the free margin is called as the lunule. So these are the features that we look in the aortic valve. And please note, as I told you earlier, look at the number, because the number, reduced number or an increased number can lead to problems in the function of the aortic valve. So these are appearances of the aortic valve from the ascending aorta. we have just opened out the ascending aorta, and all these are abnormalities of the aortic valve producing severe degree of aortic stenosis. So here we have an aortic stenosis produced by chronic rheumatic heart disease. The commissures of the aortic valve are fused. All the three semilunar cusps are markedly thickened. In contrast to that, in this particular image, we can see that all the three commissures are normal. There is calcification of the three semilunar cusps, and all these produce a heaped up masses which are nestling in the sinuses of valsalva. So this is calcific aortic stenosis, which is occurring especially in the elderly population. Note that in both these images, the commissures are present at the same level. In contrast to that, here we see that two commissures are present at the same level, while the third commissure is present at a lower level. This low level or this ill-formed commissure is termed as raphe, and this raphe shows the presence of thickening, nodularity, and calcification. Along with that, there is also some degree of fusion of the one of the commissure, and this has resulted in a bicuspid aortic valve which has an anterior and posterior configuration. So this is aortic stenosis produced by a bicuspid aortic valve. Once again, we have a calcified, rigid aortic cusp, and note that there is only one true commissure. So this is an example of a unicommissural, unicuspid, calcified aortic stenosis. So these are the some of the abnormalities which can be seen with sudden cardiac death affecting the aortic valve. Like vegetations over the mitral valve, we can also have infective vegetations affecting the aortic valve. It can be clearly seen that this patient was obviously jaundiced because the endocardium as well as the intima have an icteric tinge. So also even the vegetation appears greenish yellow in color, and this is present at the commissure between the coronary cusps. Now, what is the pathology in this particular left ventricular inflow tract? It shows three important features. The first, which is very obvious, is a bicuspid aortic valve, and this patient also has a single coronary ostium. Along with that, there is critical stenosis of the left circumflex arteries. So these are very clearly, you can appreciate these features. But the subtle feature noted is present in the left ventricle over the septum, where we see some kind of a depression. So, whenever we see any kind of depression or niche in the left side of the interventricular septum, which is supposedly smooth, we always have to take a transverse section. And when we took a transverse section, we could see that this patient with a bicuspid aortic valve had a closed muscular type of ventricular septal defect, and all this is nothing but a fibrous obliteration which extends from the left ventricle to the right ventricle. So please note that all these subtle abnormalities have to be seen and have to be dissected. The coronary ostia are supposed to arise from their respective sinuses within the sinus of Valsalva, but here we see that the left main coronary artery is present way above the sinotubular junction. So this is called as a high takeoff of the left coronary ostium. Now, here, both the right and the left main coronary artery seem to arise from the left coronary sinus of Valsalva. So, this subtle abnormality or this innocent looking abnormality can produce sudden death, and this was a sudden death in a 27-year-old male patient who was working over the treadmill. Now, apart from the origin, we also have to look at the patency of the coronary ostia. So here, both the coronary ostia are narrowed because of a classic tree bark appearance of the ascending aorta, which is also dilated, and it also shows superimposed atherosclerosis. So this was syphilitic aortitis, which can sometimes be seen once maybe in 2 years. Now, this patient has got complicated syphilitic aortitis because there is an ascending aortic aneurysm, there is coronary ostial stenosis, and there is also significant aortic regurgitation. Why? Because the aortic annulus is dilated, and because there is dilatation, it has very beautifully produced separation of the commissures, and that is why you can also see jet lesions of aortic regurgitation, which has again resulted in left ventricular dilatation, and the hearts in such cases are called as cor bovinum, or heart extremely enlarged hearts resembling those found in the cattle. Here we have obliteration of the left coronary ostium because of an atheromatous polyp. Now, what is marked in this left ventricular outflow tract is the position of the membranous septum. On the right side, the membranous septum was located at the anteroseptal commissure, but on the left side, the membranous septum has its roof formed by the adjoining halves of the right and the non-coronary cusps. And what is very important to note is the aorto-mitral continuity. That means the anterior mitral leaflet has a fibrous continuity with the adjoining halves of the left and the non-coronary cusp. So any pathology that affects the non-coronary and the left coronary cusps, whether it is calcification, whether it is vegetations, can extend onto the non-flow surface of the anterior mitral leaflet. So once again, I reiterate that the mitral valve has only a true posterior annulus. So all the dilatation, all the calcification is restricted, initially at least, to the posterior mitral annulus. And why we have to worry of the membranous septum? Because sometimes we can even get closed perimembranous VSD. So here we see some kind of a depression of the membranous septum, and at the lower rim of this membranous septum we have an endocardial ridge which can give rise to a subaortic type of aortic stenosis. Next, we come to examination of the aorta. So the aorta can just be cut open as we have done in this particular case of the aorta, which shows extensive atherosclerosis with an aneurysm present at the thoraco-abdominal aorta. And depending upon the disease, we may even bisect the aorta, as we have done in this case of a Takayasu aortitis occurring in a pediatric patient, where there is thickening of the entire aorta, and we can see obliterative changes even of the aortic arch arteries. Sometimes we may take serial cross sections of the entire aorta. This was done in a case of extensive atherosclerosis in a patient who had peripheral vascular disease, and the entire aorta is occluded by the presence of fresh fibrin thrombus. And this serial cross sections of the descending and abdominal aorta was performed in a case of type 1 chronic aortic dissection. So this is the true lumen of the aorta, and this is the false lumen of this aorta. So this is basically a double-barreled aorta. And sometimes what happens, the despite doing a detailed autopsy, the heart remains structurally normal. There is no abnormal histopathological finding. There is no cause of death identified at post-mortem, and even the post-mortem investigations are also normal, and then we may have to proceed beyond morphology. And hence, what we realized in our experience, that along with the pathology, we also have to take help of the medico-legal expert. We may have to rely not only on light microscopy, but we may have to employ other ancillary techniques, and hence we have to form a team which is composed not only of pathologists, not only of medico-legal experts, but also experts from other fields of medicine, so that Finally, the autopsy findings translate into something beneficial to the deceased family and finally to the society. So here I have to acknowledge my teachers, Dr. Deshpande, Shivraman, and Dr. Pandit, my godfather, Dr. Jagdish Bhutani from the Toronto General Hospital, Dr. Mary Shepherd, Dr. Ivana, and members of the AVCVP, and of course to my two true right hands, my fellows, Dr. Sharanya Singarvel and Pranita Zare, who have helped me in preparing and in getting more and more experience in cardiovascular pathology. So, with that, we finish the examination of the heart at autopsy. So, this was the ABC. Thank you very much.
Thank you for a wonderful lecture, sir. I don't think we have any questions on the Facebook page at the moment, but we do have greetings from Hungary and Manchester. So, hello to our viewers.
Thank
I would,
you and hello.
yes, hello. And I would like to invite the panelists to begin asking questions and sharing their comments.
I would just like to add a point.
Hello, sir.
Can you hear me?
No, madam, your voice is very low volume.
Okay. Is it better now?
Yes, ma'am.
Okay. Um, One important structure on the left side of the heart is the left atrial appendage. And we often don't look at it very carefully because it is a tiny, measly, little worm-like structure. But there are two important aspects to the left atrial appendage. One is one has to examine it carefully for the presence of thrombi, because many times these thrombi can embolize, and especially in patients with atrial fibrillation. And nowadays they use devices to block the atrial appendage, and therefore um, some studies have taken recently about the morphology of the atrial appendages. So atrial appendages can have chicken neck appearance, it can have a cauliflower like appearance, it can have a windsock like appearance, and so on. Most of these
Cactus.
are on radiological examination, but it is of importance for clinicians who are involved in devices used to block the atrial appendages. And forensic pathologists also have to examine it, especially in cases of blunt trauma. See, the left atrial appendage has got very thin wall. It's got those pectinate muscles, and in between the musculature is extremely thin. And when there is a blunt trauma, often there may be a tear in the left atrial appendage. So that is a structure to which most of us don't pay much of attention, but I think we should look at it in most of the situation. Even in mitral stenosis, atrial appendage will have thrombi sitting there, and therefore it is of importance. In earlier times, the surgeons used to just tie the neck of the atrial appendages, but nowadays with so many devices, they use a device to occlude the left atrial appendage.
I hope the reviewers remember the morphology of the appendage, all of which we had covered in the first session of external examination. I think someone was asking.
Shashank started to say
Yes,
something.
sir.
Yeah,
Yes,
yeah,
sir.
yeah. Yes,
Sir,
Dr. Shash.
I like to ask one question. I like to ask one question. Am I audible, sir?
Yeah, sure. Yes.
Yes, sir. Sir, in case of young adult death, if there is a finding of congenital malformation of chordae tendineae, what other investigation we can do to give the final cause of death?
No,
Like
these,
we have done one case where there is a
yes.
chordae tendineae malformation. So, what others we can do investigation?
No, no, it depends upon what type of malformation we are talking about. Because very often the malformation of the leaflets go hand in hand with the malformation of the chordae tendineae. So that is why a careful inspection of the mitral valve is required. And in one of the photographs which I had shown you earlier, there was only a malformation of the chordae tendineae where it had that sort of meshwork-like appearance. So that may or may
Yes,
not
sir.
produce any clinical significance. So it depends upon how you're going to describe the chordae tendineae malformation versus the appearance of the rest of the valve. And along with that, we also have
So
to
for
look at the position of the papillary muscles. So that also might make a difference to the appearance of the chordae tendineae. Because nowadays, again, there is lot of work which is done on the appearance, the size, location of the papillary muscles and the pattern of origin of the chordae tendineae and their insertion to the valve leaflets. So a lot of studies are there to explain, because sometimes they say that the basis of a particular malformation depends upon the placement of the papillary muscles as well. So there might be an anatomic basis to the degree of, say, stenosis or regurgitation that occurs in a particular patient.
thank you, sir.
Are there any more questions?
So, sir, to give the final cause of death, we can show the references when we go to the court. That on the basis of these references, we are giving this cause of death, as per the latest article is like published there.
Yes, definitely.
Okay,
Yeah.
thank you.
Thanks.
I don't think there are any
Hello,
more.
sir. Hello, sir.
Yes, Dr. Manoj.
Yes.
Yes.
Sir, excellent presentation, sir. Very nice
Thank you.
photograph. Yes. Sir, that you have said in your slide that the main purpose is that we have to include pathologists, medical legal expert, anatomists, genetics. So that idea is very excellent, sir. I like this idea. And in BMC only, sir, we have the combination of pathologist and forensic expert. They are doing the postmortem in medical negligence cases. But in other parts, sir, the pathologists are uh, hesitant to conduct the autopsy with the forensic person. So I like to share this idea that if the more combination, more person are involved in autopsy for the beneficial of the society, that will be excellent things. Thank you.
Yes, thank you. Now, I like to quote, like, for example, Dr. Robert Anderson is an anatomist. And look at the volume of work that he has done in congenital heart disease. So
Yes,
every specialty has to have some kind of an input for cardiovascular disease. Only then it becomes, relevant, I mean, to the clinician as well as, and possibly that nowadays we'll have more and more sophisticated imaging modalities. So definitely more and more specialists will have to come into field.
yes,
So every subject should have an applied part to it that way.
yes.
Yes.
Good
Thank you.
evening, sir.
Thank you.
So good evening, sir. Can I ask a question?
Yeah, sure,
Uh, Sir,
Dr.
this
Nagesh.
yeah, like in a valvular stenosis, whenever like I mean you want to like I mean give a cause of death if because I had one case like mitral stenosis, but of course it was a very I mean critical stenosis like what is that fish mouth appearance something like that. Sorry, not a keyhole appearance, and that was okay. Otherwise, actually, what is the percentage of stenosis where actually we can take it as a cause of death, or any other pathology should be associated to prove it as like it's a cause of death?
Yeah. See, what we do is if the stenosis is moderate or severe,
Yeah,
we say that this has definitely contributed to death.
yeah.
Yes.
Moderate to
And you
severe.
also have to look at the circumstances. For example, a moderate stenosis in a pregnant woman, if not, properly managed, is capable of producing mortality. So it always depends upon the circumstance of death along with the presence of moderate stenosis. If it is severe stenosis, yes, we have seen several cases of sudden cardiac death because of severe rheumatic mitral stenosis.
Along with that, any like pulmonary pathology should be present. I mean, to correct as a 100% it is due to like mitral stenosis or something like that.
Yeah, you can always correlate with the other organ findings, like especially the lung, the liver, and the kidney, because
Okay.
that is how that congestion is going to occur. And plus, you will also have features of pulmonary, venous pulmonary hypertension. So, all that will be an additional feature for saying that it is because of this critical or moderate degree of mitral stenosis.
May I have a question?
Yes, yes, sure.
First of all, of course, thanks for a great lecture full of really beautiful pathologies. But we know all that we have also cases of sudden cardiac death where we have microscopically, even microscopically normal heart. In
Right.
this kind of cases, what is your opinion? How many pieces should be taken, and what is like your approach in this kind of cases where there is suspicious for sudden cardiac death and you have morphologically normal heart?
Yeah. So what I do when the heart is normal, we usually take whatever you people have recommended as far as the AV-CVP is concerned, like take sections from the anterior, posterior walls of the right ventricle, right ventricular outflow tract, basal, mid, and apical third of the ventricles, 4 sections. And I also, and once if all these sections are normal, only then I very reluctantly go and take sections of the conduction system. And then if that also is normal, then it is a full stop for us, because we do not have any institutions who do this molecular genetics. So for us, if everything is normal including the conduction system, then we are at a dead end. We can't proceed beyond that.
Yeah, but at least those specimens are taken, so they are there for the future. So
Yes,
it's really,
yes,
it's very
yes.
important that it's
Right.
sampled.
Yes, yes.
Yeah, and it's nice you mentioned this AACVP
Yeah,
protocol.
yes, yes.
Yeah, thank you for that,
Thank you.
and thank you for your answer.
So we have greetings from Sheffield. Julian says hi. And Harish would like you to organize a sessions on congenital cardiac pathology in fetal examination. And we have a visitor from Korea, and I hope I'm pronouncing his name correctly. It's Jong Buk Seo, and he would like to explain about your collection, and do you have a specimen collection, and how many autopsies are performed in a year?
Um, See, when, for example, when Dr. Deshpande was my professor at my institute, we used to do close to 3,000 medical autopsies. But unfortunately, the number has dwindled. So it has now roughly come to 400 autopsies, which are done by Department of Pathology. And because we have got such an excellent rapport with the forensic medicine, we do additional about 400 medico-legal autopsies. So total 800 autopsies are performed by Department of Pathology with or without forensic medicine. And we have a collection, I think Madam Deshpande will agree, at least about 10,000 specimens we have as in our archival material of all congenital as well as acquired lung, heart, and mediastinal lesions. And if I include heart and lungs and mediastinum, it might go to maybe around 12 to 13,000 specimens.
And also a huge collection of photographs.
Photograph roughly is 22,000.
It's really impressive number.
Thank you. It is all thanks to the guidance of my teachers who have always told us to have a photographic evidence, almost like, medical legal photographic evidence.
So I think that takes care of the questions for now, sir.
Sir, you should give
one more comment is that arranging fetal congenital heart disease would be fatal for me because I don't have any experience. But there are a few experts in south of India who have devoted body and soul to fetal autopsies, and we will definitely talk to one or two of them, and maybe next time we can organize fetal autopsies and congenital heart disease. Thank you. That's a wonderful idea. Thanks.
Sir, one session should be on how to take photography. No, it is so excellent and it is very informative. I think we need to learn that art.
For me, it is almost like a religious ritual, taking photos.
Yes, yes, sir. So that's why if time permits in future, you kindly arrange
Sure,
one session.
sure.
Thank
Definitely.
you.
Yeah.
I think that has been a lovely series on cardiac anatomy and dissection, and I hope that all the viewers will now join us for our future plans, which is basically going to focus on the microscopic appearance of the heart. So, Sir has been taking sections and taking photographs. He's been hard at work. So we'll come back shortly with a live microscopy session on cardiac histology. So I hope that everyone will come back again for that. This talk and all the previous talks of this series are available also on our YouTube channel as well as on our Facebook page. So if anyone would like to go back and review anything that they have seen earlier. And then we come back on the 27th of this month for Dr. Mary Shepherd's talk, which is going to be on myocarditis. So that's going to be really interesting as well. Yeah. So
thank you.
Thank you so much, everyone, and see you next time.
Thank you, everyone.